Right, we're so glad to have Dr. Amanda Albert to join us today. She's one of the most brilliant people I've ever met. And not surprisingly, she went on to become a doctor. And not only that, did her master's and also obtained the membership of the Royal College of Psychiatrists. And of all the specialist programs that you can take, she took the hardest one, and that's psychiatry. And not only is she a practicing psychiatrist, she's also a lecturer at UNIMAS in Kuching. She was naturally a leader in our campus alive and our youth in church, as well as in IMU, where she was studying before she went to Australia. She was also the CF leader. So we're so glad to have her to share with us today on a very interesting talk on depression. Let's talk. So you can ask her any questions that you like. She's an environmentalist, as well as a person who loves dogs and rescues them, and then also has a big interest in the impact of social media on mental health. Enjoy the talk from Dr. Amanda as she comes and tell us a bit about what's going on in our minds. Hallelujah. Let's give a warm welcome to Dr. Amanda.
Okay, I am so glad to be here today. As usual, as it is when I visit New Life, this is like visiting family again. This is like coming into a place that I am so familiar with, and it's like home to me. It always feels warm, it always feels welcoming. So we are virtual, but that's a sign of the times, unfortunately. Hopefully, we will be able to meet up in person in future. Yeah, so I'm really, really glad to be able to have a little bit of give you all a little bit of an idea of certain mental health issues that we commonly deal with in the world that we live in today. I think it's actually a very, very big area. And when Pastor Joshua said that it's the most difficult specialty, it's more probably the fact that it takes a long time to treat. You can treat an infection with antibiotics, and in 3 days you start to feel better. You can do a surgery, and in 2 weeks maybe you are better. But with mental health issues, they take a long time. They can take a very long time. They can take weeks, months, years to actually feel, to actually improve and to actually gain some sense of your old life back, right? So I intend for this to be quite a chill introduction, right? Since we will be spreading this over 3 weeks. But of course, I intend to have time for questions as well. So I'm open to questions at any point. And let me share my screen. There you go. All right. See slideshow. Okay. So let me just give us a bit of an overview. The thing about mental health issues is sometimes we just bunch everything together. Okay, everyone just says that, oh, okay, mental issues like the same across the board. Okay, this and that and everything, we just say, oh, mental issues. But actually, if you look at this slide, which is why I wanted to start with this, just to give us an overview so that everyone is on the same page. There are a few major groups of mental health issues. Okay, one is relating to the emotions. So if you look at the first one there, you can have depression, like Pastor David was talking about, where you're just down and you're just feeling really, really terrible, very, very down. And that is on one pole. Okay, if you think about the North Pole and the South Pole, 2 poles, right? 1 pole. On the other end of it, you have bipolar disorder, which is 2 poles. Somebody becomes super, super happy for no reason, and to the extent that they put their lives at risk, right? Because they are too happy and too energetic. And then, and the same, in some time later, they become so depressed, like somebody who is who has depression on 1 pole. So that's 2 poles, and that's called bipolar disorder. And then there are other disorders related. Okay. The another big group is psychotic disorders, where you hear things, like you hear hallucinations, or you see things that are not there, or you believe things very strongly. You believe it very, very strongly when other people do not. You believe even things that are impossible when others do not. Okay, when your family finds that that's unusual. So that may be a psychotic disorder like schizophrenia. That's one group. Then another group is anxiety, which a lot of us will be quite familiar with. Feeling very kanchiong all the time. Okay, a lot of anxiety, having panic attacks, right? Some people have trauma and then they have stress after that, which is post-traumatic stress disorder. Obsessive compulsive disorder is another one that people have, where you have to clean your hands multiple times, for example, or if you arrange things, you have to arrange them very, very straight, right? And it's to the extent that it disturbs your life, it takes over your life. So that's OCD. So that's a group of anxiety disorders. Okay. And then there's another group of mental health disorders that's related to physical health problems. So some people may have a thyroid problem that they never knew about. And the first symptom that they have of it is actually depression, for example. But so it's good if you do have some mental health issues to actually undergo a full medical check to make sure that it's not one of these problems. Some brain tumors can cause people to hear voices or see hallucinations, right? Some people who have fits like epilepsy can have the same thing, right? So there are some mental health issues that look like they are mental health problems, but actually they are caused by physical illness. Okay, so that's one more group. So if you treat the physical illness, in a lot of cases, the mental health problems go away. So that's important to realize. Then another group is alcohol and drug-related disorders. Okay, so that one is relating to alcohol and drug abuse. So those two sort of like they build each other up. Okay, alcohol and drug abuse can worsen mental health problems, or can even cause mental health problems. And then mental health problems worsen the drug and alcohol use. So it's a cycle. So what we will be talking about today is mood disorders specifically. Okay, so that would not, we will not be talking about the hallucinations, we'll not be talking about anxiety, although I know that that's, there may be questions that come from there, feel free to ask, okay? But in the coming weeks, we will cover some of these others as well. Okay, so when people say depressed, what do we mean? Okay, does everyone who feels sad, can everyone who feels sad be diagnosed with depression, for example, right? And in fact, if any of you remember the movie Inside Out, and you see this character there, Sadness, right? Sadness actually has a very important role in the movie. Okay, just like happiness, just like anger, all our emotions have an important role to play in protecting us and helping us with life. So sadness has a role as well. Okay, but the question is somebody actually just sad, or is somebody actually depressed? Okay, so feeling down is really part and parcel of our life, but depression is a very different story. Okay, so if you think about depression, it's actually a major illness worldwide. Okay, and a lot of the time we think about illnesses that contribute to disability in the world, people who are disabled because of the illness. We think of back pain, we think of heart problems, right? We think of accidents that cause people to have disability. But actually, the statistics show that depression is a leading contributor to disability. So it disables people, right? And in a lot of the statistics, depression is at the top number 1 or top 2 of the illnesses that disable people, that make them unable to work and unable to continue with life as usual. Okay, so that I know that's surprising for a lot of us, because we don't really think about depression as a disability, but depression disables a lot of people in the world. Okay, and it affects about 5% of the global population. If you think about 5%, that's 1 in 20. So there's 100 of us here, maybe 5 of us would have experienced depression or still experience depression at this point, right? 75% of the sufferers in low to middle income countries do not have adequate treatment. And if you think about it, we are a middle income country, according to the WHO. So many of us actually suffer without treatment, even though treatment is readily available. Okay, and then statistics also show that 1 in 5 of us will experience a major depressive episode, okay, which may or may not become a long-term depression, but an episode, 1 in 5 of us will experience it in our lifetime. So if you count that, that's at least 20 people in our church service today of 100 people, right? So it's really quite significant, and of course, it's a major contributor to suicide deaths. You may have heard about the increased number of suicides during this pandemic. It's a major contributor as well. Okay, so let's look at depression as the therapists define it, or as the psychiatrists and the clinical psychologists define it. Now, if you look at that small blue book in the upper right corner of your screen, that's the DSM-5. That's the manual we use. It's like the Bible of psychiatry, the Bible of mental health. Every possible diagnosis is there with criteria on how to diagnose it. So how does somebody get diagnosed with depression versus just regular sadness is these 9 symptoms, you would need to have 5 of them. Okay, but 5 of them must involve you must involve at least one of those 2 highlighted ones. You see the 2 highlighted in purple, feeling sad on most days or losing interest in most things on most days. Okay, if you have one of these or 2 of these, both of these, combined with some other symptoms in the other boxes to make 5, that would diagnose you clinically as having clinical depression already. Okay, so you're feeling sad, you're losing interest in most things, and then you combine it with other things like eating too much or too little, putting on or losing weight, not able to concentrate, feeling very worthless or guilty for no reason, sleeping too much or sleeping too little, having no energy, right? Repeated thoughts of death or suicide, or slowing down or moving too fast. So others will see this just becoming very slow when actually before this you're very fast, or being somebody who's very restless. Normally you're somebody who's calm, but your family sees you getting very, very restless all the time. That could be a sign of depression as well. Okay, so we have a very specific criteria in this sense to diagnose. And if you think that, you do fulfill a lot of this, including the first 2, one of the first 2 or both of the first 2 highlighted ones, then you may have an episode of clinical depression. Okay, all right. So what we've talked about what depression is and what depression is not. I'd just like to remind us a little bit, okay? Depression is not just in the head, okay? Depression is not just attention seeking. It is not a sign of weakness or lack of faith, okay? In fact, I put it to you that the Bible actually has evidence of people who have had that kind of sorrow that is described as depression. Of course, they don't use the term depression, but the way they describe their sorrow sounds a lot like people who have depression, the way people who have depression describe their sorrow. Okay, we consider people like Job, right? People like Jeremiah who said, just let me die, right? David, during his own period where his soul was downcast, okay, and he comforted himself in the Lord, right? And even Jesus, right? His soul is weary to the point of death. That sort of like crushing grief and sorrow that swallows you up. That's what depression is. It's not just a mini sort of sadness. It's not a normal part of up and down of life, but it's a very consuming sorrow. Okay? Depression is also not a person's fault. We like to think that it is. And sometimes with all good intentions, we think that, if only she lived like this, then she wouldn't be depressed. Or if it's the person's family's fault, if only the family didn't do this, if only the mother didn't force her, if only the father wasn't an alcoholic, if not, you have all these other theories, about what depression is or what caused somebody's depression. But the truth is, if you look at the history of the people who have had depression and even people who have committed suicide after having episodes of depression, a lot didn't have these family problems or didn't have these personal problems. You can actually be depressed without having any reason to be depressed. It is possible, right? So we can't just narrow it down to like, this is the reason for the person's depression. And depression is also not the same as all these other disorders we talked about. Okay, so one of the worst things we can do, because we don't know, is to lump them all together and just say, all the same. Okay, and then all mental issues are all the same. But it's actually really, really different. And even the treatment is different. Okay, so if you what does cause depression? It's usually a mix of these things. Now I've put this out here as like a list of ingredients, and this was a slide I used when I talked to the youth about depression like some months back. Okay, but it's usually you don't bake a cake with just one ingredient, and usually the cause of depression is multiple things leading to one thing. It takes multiple ingredients to bake the cake of depression. Okay, so one thing could be medical conditions that can contribute to it. A lot of the studies show some differences in the structure of the brain or the chemicals that run in our brain to help it to work. So that is and that is how some of our depression medications help as well. Okay, antidepressants help by sort of like balancing out these chemicals. Okay, so that can be a cause. Genetics sometimes, it is true that if you have a family member who does have mental illness or depression of some sort, you are at higher risk compared to somebody who doesn't. But then again, that's not always the case. All right. Drugs and alcohol is another one. And stressful life events, of course. So trauma, stressful life events, violence, history of abuse, family issues, studies, relationship issues. Any number of things, job difficulties, all these things can contribute. Okay, so usually point of the whole matter is that there's multiple factors, usually multiple ingredients leading to it. Okay, and I have good news as well that by the grace and the inspired wisdom of God, there is treatment available for depression. Okay, we generally put them into three groups. One group is self-care. So finding your refuge in God is one. There is proof that a lot of studies show that having some sort of faith or religious belief does protect against depression as well. So finding your refuge in God is one. What I mean by finding refuge, I know we pray, we read the Bible, we spend time with the Lord, but finding refuge means, I specifically picked that because I want us to have the idea that we can be honest with God about our depression. The depression doesn't have to be a sin. That in fact, even if you denied having depression, God knows you have it. So there's really no point in trying to not be honest with God about your struggles. I think God can handle our struggles very well. He has a history of handling humankind struggles for a long time, right? So that's refuge. Having some sort of social circles with people you trust, right? Exercise, diet, hobbies, and art, all these things are part of self-care. Okay, you'd be amazed that in my line of work, when I ask people what their hobbies are, many people can't tell me, right? Taking care of the children, although enjoyable, and even if children are the love of our life, is not a hobby, right? Cleaning the house or doing the house chores is not a hobby. What I mean by hobby is something that makes you feel alive and something that you enjoy, right? So if we don't have hobbies, it's time to find them. I think I find that a lot in my line of work. Yeah. And then one more group of this is talking therapy. So sometimes self-care on its own doesn't work fully. So we see there's counselors who do a certain type of, who listen to your problems and help you to solve problems. Clinical psychologists are another group, right? Who help people with more advanced sort of therapy. And this is the kind that has a lot of that works very well for depression. And support groups is some. Okay. And of course, at the end of it, there's medication. All right. I also, one of my interests is actually destigmatizing and medication in Christian groups. I do think that sometimes, although it's true that the Lord can heal us at any point that He wants to, and it is true that we seek for healing in the Lord, I also do think that the Lord has given people wisdom, just like people wisdom to find, find medications for anything else. The Lord has given researchers wisdom to find antidepressants to help people. I think that if we don't open the conversation about antidepressants in our Christian groups, then we risk alienating people who do need medication to help. And for a lot of people with depression, medication helps, at least until they get they strengthen their other parts of their lives, or at least until that stressful period of life is over. Antidepressants do help. Okay, and of course another one that raises a lot of questions usually is electroconvulsive therapy, electric shock therapy. Okay, this one is stigmatized a lot. People have a lot of wrong, sort of like older misconceptions about what it is. But the truth is that we find that it is very, very effective for severe depression, especially people who are very suicidal. It brings down the suicidal thoughts very quickly, a lot more quickly than medication. Okay? All right. So as we go through this pandemic, okay, I know all of us would be struggling in different ways. How can we take care of our mental health? Okay, so these are a few things that I think we could find helpful. One is actually to stop and check your own emotional temperature. So actually say, you know what, am I okay or not? Am I okay? Sometimes we get busy, we take care of others, we take care of ourselves, we get very busy with work. It's like online thing after another, and then we worry about COVID, we worry about SOP, we worry about everything. But really, a good thing is to just stop and check your own emotional temperature. Am I okay? By stopping and doing a self-check, I have found a few times that I'm not okay during this period of the pandemic, right? So to actually stop and check. So it brings me to number 2, that it's okay to not be okay. Like I said earlier, God knows and he's not afraid of your honesty. So dear God, you can actually tell him. Okay. I think the next thing that I think I mentioned earlier as well is to really take care of your physical health. So things like exercise, food, sleep, brain engaging activities, right? And to learn self-care and practice it like a new SOP. Self-care is not a very Asian concept. The Malay have a saying, like the candle, like burning yourself, the bagaikan lilin yang membakar diri, like that. You sacrifice yourself for others. And we view that as something very noble, which it is. But really, a lot of times we also need to learn to take care of ourselves. Okay, so what are my hobbies? And if you don't have an answer for this, perhaps now is the time to look for what exactly are my hobbies, what makes me feel alive, what makes me feel like, for a moment I can forget my troubles. Okay. And number 4 is to stay connected with the people you trust. By this, I don't necessarily mean the people that you should stay in contact with or you think you should. What I mean is people you trust. If there are people you trust, it's important to maintain that connection, even if it's not the same in the virtual world. Okay? Finding creative ways to stay in contact, there are all sorts of things online now. Finding creative ways to stay in contact will fight depression as well. Now, another big one is number 5. To beware of the social media and WhatsApp trap of doom scrolling. If you haven't heard of doom scrolling, it is basically where you scroll, you open up Facebook and then you scroll, and you keep scrolling. Instagram, you scroll, and you keep scrolling. And then the scrolling doesn't end to the point that it's like boom. You don't realize that you get sucked into this trap. And after you're done with this time here on this, you feel more terrible about the world and more terrible about yourself. Okay, so I would actually advise to just be really careful of how we spend our time watching social media, forwarded videos, forwarded messages, right? Half the time we don't know whether it's verified or not. We need to be quite careful. To beware of the trap of comparison. Now, there have been studies, with children and young people who have body image issues in the UK, and even in the US, the UK and the US, they found that during this pandemic, the body image issues have gotten worse. The starving of themselves, refusing to take food, over-exercising, right? The body image issues in these young people have gotten worse because of the increased time spent on social media. And with the increased time, they compare themselves a lot. It's the trap of comparison, comparing yourself to each other, during the beginning of the pandemic, people talked about, getting fit, and there were all sorts of virtual plans about how to get fit, things like that. But that was actually bad for the young people who already had body image issues, right? So we found that their depression got worse, their anxiety got worse, it got really bad. So I would say to be a bit careful of the time we spend on social media and our chatting apps, to actually take time to detox. All right. So a question to ask yourself is actually, am I feeling worse after my phone or computer time? And if you're feeling worse, then it's really time to just, put a time frame on it and say, okay, after 5 minutes, I'm out. Set an alarm, that kind of thing. All right. Now, if all of these things do not work, or if you feel suicidal at any point, I would strongly recommend seeking professional help. I mean, even virtual options are available today. It doesn't even have to be in person. It's very, very accessible. I would actually recommend this lah. Yeah. And I mean, I'm happy to take questions if anyone wants to ask where they can do so. Okay. So how can I help? If I know somebody who's depressed and I think they may need help, especially tailored to our Christian circles, I think one thing is actually to seek more understanding. It is true that depression may have some spiritual component, okay? Whether it's like spiritual attacks or whether it's like, the devil's lies, right? It's true. But not all of it is spiritual. Some of it is actually biological issues in the brain. Some of it is psychological, when Pastor David earlier mentioned about the thought process, the negative thoughts, they just go on and on and on. And there are therapies for this, okay? Prayer and praying in the spirit is one. There are therapies, actually formal therapies that you go through with a therapist that can help with this. So actually to seek more understanding in our Christian circles, I think is really important. So we do this by reading up, listening to others' experiences. And when I say listen, I mean learning to listen, right? The second one here, to listen without judgment and without giving advice, and just learning to be present. A lot of the time, when I talk to young people who have depression in Christian circles, the biggest difficulty they have with being honest about their struggles is really the fact that, yes, the people in the church listen to me, but they always have some sort of advice to give, that is some sort of spiritual advice to give. We're so quick to give spiritual advice because we feel that scripture has helped us a lot and scripture is the answer to our problems, right? So we give a lot of advice automatically. But sometimes, if you remember, Pastor David mentioned earlier as well, when he was feeling down like that, it felt almost terrible to meet positive people who had positivity all the time as well. It's very, very hard because it feels like this person is in this positive world and I am in this negative world and nobody really gets me, right? So this is the difficulty I found. People who are Christians have told me that they have difficulty talking about it in their churches because we're so quick to give advice straight away. We're listening, we're giving advice, spiritual advice of some sort straight away. But really, a lot of the value is learning to just be present and to just listen and say, you know what, I'm here with you. I'm here with you. How can I help? How can I pray for you? How can I help? Right? Also, do be careful with advice. Be strong, be positive, have faith, pray more. All this when somebody is really in the deepest valley of depression, that's not helpful. A lot more helpful is really, like I mentioned earlier, how can I help you? Are you okay? I'm here with you. Just tell me if anything. Just tell me, and just be there and just say, it's okay. I hear you. It's tough, very tough. That has a lot of power, right? And of course, as we go along, your spiritual advice does take some role later on, right? But certainly not in the first time that somebody is telling you that they're depressed. Okay. To encourage seeking help eventually. Sometimes people don't want to see a psychiatrist straight away, right? There's a lot of labeling that comes with seeing a psychiatrist or mental health professional. So some people will respond to going to see a counselor first, maybe a counselor just to chat, talk about problems, right? But this, let me remind us, is not applicable if the person is in a crisis, if the person is suicidal or has harmed themselves. That we encourage seeking urgent help straight away at the hospital or at the clinic, right? Yes. So, any questions? Does anybody have any questions as we go?
Amen. Very good. Thanks a lot, Dr. Amanda, for the wonderful session, which is very, very helpful. Put a lot of things into perspective, and very balanced. And there's one question on the chat box.
Okay.
About whether antidepressants will cause mood swings. And if you have any other questions, please either type them on the chat box or you can just unmute yourself and just ask Dr. Amanda directly. Amen.
Yeah. Right. So, do antidepressants cause mood swings? I guess that depends on what the mental health condition is. Okay. If the mental health condition is depression, like clinical depression, and you take antidepressants, some people may have a period in the first few weeks where the mood goes up and down, where the mood feels a little bit unstable before it gets better. So that's why sometimes you hear people say, I took antidepressants and I felt worse. I actually stopped because I felt worse. But the truth is it didn't go beyond 2 to 3 weeks, right? Sometimes it is true that the emotions do get a bit unstable in the first couple of weeks. And then after that, we start to see the improvement in the mood and improvement in the symptoms. So if we mean that kind of mood swing, then that can occur. It shouldn't cause mood swings long term. If it causes mood swings long term, then it's worth talking to the doctor about whether this antidepressant is suitable for the person, right? Now, there is one exception. If somebody has bipolar disorder, okay, so when he came to see the doctor, he was in the low phase, right? And he hadn't had a high phase yet. Remember when I mentioned earlier, people with bipolar disorder swing from extreme highs to extreme lows, right? So this person sometimes comes in an extreme low sort of stage, and we don't have a clue about the extreme high part. So we start an antidepressant. In those cases, the mood swings can get very bad. And if the mood swings get very bad, then maybe this person has bipolar disorder, but he came with the depressed part of the bipolar disorder, or it may be that he has this bipolar disorder. So I would say that if the mood swings are prolonged for a long period of time, right, even beyond the initial bit of treatment, then it's worth talking to the doctor to see whether this one is suitable for you or whether you actually do have depression or something else. Yeah. Yeah, I think that is my take on it lah. Anybody else?
Dr. Amanda.
Yes.
Yeah, okay. So what if a condition, maybe not depression, but a feeling where you don't feel things after taking medication? So, okay, like for me, a few years ago, I took Esmaya.
Okay.
So that's a medication to, I think, suppress luteinizing hormone to stop the uterine fibroid.
All right.
So, and then it's not that I feel depressed or anything. I don't have mood swings, but it's almost like the mood is totally flat. So when there's something happy, you don't feel happy. When there's something sad, you don't actually feel like crying. Or when something is upsetting, you don't feel angry. So is there such thing?
Yeah, that's definitely possible. That would come under the category that I mentioned earlier, mental health disorders that are related to a physical illness or actually to a medication. It is true that some medications can cause people to have these type of symptoms. That's probably due to the fact that it modifies your hormones, right? And then along with that comes a modification of the mood. It's possible. Yeah, it's possible. So say if you had a very bad situation with the emotions, but you're on a medication that needs to be, if it's short term, then never mind, right? Probably it will clear after you stop the medication. But if it's a medication that is required to be on long term, and if the mood, the emotion problems get to the extent that you think you need to find help, and to the extent that it's affecting your life, all right? So that's the key to diagnosing clinical depression, that your life is affected, your work is affected, your relationships are affected, right? When it reaches that point, then maybe it's worth talking to the doctor to see whether you may need a small course of help. I mean, either talking therapy or medication or things like that for that.
Okay, yeah. So it's all right to manage it because it's only a drug induced mood.
Yeah, there are quite a number of conditions that look like the mental health disorders but are actually caused by a medication or by a physical illness. So even things like steroids, sometimes we have steroids for illnesses. Even during COVID-19, people have some people who have active COVID-19 need steroids for a bit, right? Some steroids do cause people to hear voices or see things, or sometimes they have a depression for a bit, or if you have some, so if in those cases it's a lot of people don't know that could be the cause. So if it's a short-term medication, yeah, maybe you can tide it out until the medication ends. Or if it's something that you need long term and you find that the depression is getting worse or the hallucinations get worse and things like that, then it's worth seeing a doctor to see what they can do to help lah.
Thank you. Thank you so much.
Yeah, no worries. Mm.
Hi, Amanda.
Hello, Uncle Gary. Hi.
Gary here.
Hi, Uncle
Good to see
Gary.
you. Just
Yeah.
some question. You say depression is not bipolar, right? Disorder or schizophrenia, right? Now, very often we are confused. Like schizophrenia also is not to be confused with what they call DID, dissociative disorder. You know,
Right.
so can you tell the difference between this? Sometimes I talk about multiple identity. Right? Can you tell the difference how you distinguish a depression, bipolar disorder, or DID?
Yeah. All right. So dissociative anxiety disorder is actually much more rare. Okay. Let's look at a one sentence description on what each of those are. Okay, depression is a sadness that is abnormal, that is consuming somebody's life. Okay, that's depression. Bipolar disorder is when somebody swings back and forth, swings from the low to the high, super high, and then super low again, right? So that's bipolar disorder. Schizophrenia, the main issue with schizophrenia is not so much feeling low, although they may feel low, or feeling high. That's not the main issue. The main issue with schizophrenia is actually hearing or seeing or feeling or smelling something that others don't. Okay, so basically hallucinations and or plus minus delusions, a strong belief that something is true when it's known to not be true. For example, believing that, there's microchips implanted in the brain, believing that the neighbor is out to harm me, but actually the neighbor is very, very kind to me and likes me a lot, right? So these kinds of beliefs, that one would be schizophrenia. Okay, dissociative identity disorder is much more rare than all of these three conditions. Okay, these three are much more common. You're more likely to meet somebody with all this in their life compared to dissociative identity. And dissociative identity is basically a condition where, because of something that's happened in the past, usually some sort of trauma, as a child, this person learns to form other identities to cope with it. For example, a child who is being abused by somebody that they know, and they are feeling very weak and very small. In their minds, they form another personality, a strong one. Somebody who is strong to the point that he will kill people, for example. That kind of forming a different identity in the mind to sort of like cope with the stress that's happening. Now, the key difference is somebody with dissociative identity disorder generally does not have any idea that this is going on. One, when they are switching between their identities, as they grow up, these identities stay with them and they switch between them. Sometimes in our Christian circles, we will call it like demon possession or spirit possession or something, right? Well, maybe there is some role, but then they form these identities, right? And usually half the time they have no control between the switching of the identities and all that. Okay, so it's not something that is very aware. It's something that occurs almost on the unconscious or subconscious level for somebody. It's very different from somebody who experiences symptoms of schizophrenia, bipolar disorder, and depression. They can tell you what they experience, but somebody with dissociative identity just sort of like moves between these identities without being able to tell you what it is. So it's almost like a mechanism I used to cope when I was small, and I still do it until now. The treatment also for this one would be psychological therapy. A lot of time with a clinical psychologist, a therapist. The medication is not exactly the treatment lah. So that would be the difference. One, that is very rare, and number two, the way in which the patient present. The symptoms that they report to you are very different. It's not like people who experience the hallucinations or the false beliefs of schizophrenia, or somebody who has the mood disturbance of bipolar disorder and depression. Uncle, it's quite different in that sense.
Yeah, I agree. I was asking this question because there was one Korean drama showing that this guy has got DID, dissociative identity disorder,
Yeah.
seven types, from a
Yes.
child to a corporate man to a crazy man, a violent
Yeah.
man, you know. So it changed
Yes.
your mood 7 times, you know, it can, you know.
Yeah.
So
So
I was a puzzle. Well, a person can assume 7 identity, you know, in just, you know, the span of time. So I mean, a
yeah.
lot of time we talk about split personality, double, right? But this one,
Yeah.
7 personality, you know, in one
Yeah.
person. So is it possible?
Yeah. Well, it is, but it's really quite rare.
Very rare. Huh?
Really quite rare. A lot of the time, the patients who present to me with this kind of presentation, as I talk to them further, I find out that it's not the true DID. It's not the true split personality, but it's more like they've got other issues going on, like a very severe depression, and then they form this in their minds to feel better. But the true DID is somebody who's really not aware that they are switching between these identities. It's very different, and it's much rarer. But you will see it a lot in the movies because it makes for a great story.
No, I was thinking
Yeah,
to do in a biblical sense, people who fall into this category is a kind of bondage. Like you say, in the childhood, they have kind of trauma, you know. So when they grow up, they kept themselves inside that. So it's a bondage within them. So it need to be set free. I mean, you're talking about psychiatry, okay, I find. But in Christianity, I think we believe the Bible that we should find liberty in Christ. You should break that bondage to get out. I mean, there's one way of treatment of this one. But a lot of time in medical side, they give drug and so forth, psychiatric, you know, counseling and so forth. So it's possible that, according to the Word of God, that can be set free.
For DID,
DID.
yeah, I think there definitely is there will be both a psychological therapy and a spiritual role that can be. Yeah. For other medications, for other conditions where medication is a big part of the treatment, then I think we must not go without medication. For example, in schizophrenia, we should have medication. For bipolar disorder, we should have medication together with psychological therapies and spiritual therapies, of course, right? The Lord can set us free, correct? But DID, we don't have a medication for it. It's not something that can be treated with medication. So I agree that whether it be spiritual therapy or psychological therapy, they can both work hand in hand actually to help this person. If this person really has it, the thing is, it's actually quite rare. It's much more rare than schizophrenia, bipolar disorder, depression, and anxiety. It's much more rare.
Okay, thank you.
Right, thanks, Uncle Gary. Thank you. I see here, Chun Wei Choi. Oh, there's a question here. Is bipolar disorder one type of depression? And how about personality disorder, or Billing is asking? Okay, the first question, is bipolar disorder one type of depression? It's a type of mood disorder. Okay, so one group of mental health disorders is the emotional disorders, the mood disorders. And depression is a disorder where you only land on one side, you're only sad all the time. Bipolar disorder is a mood disorder in which you're both sad, extremely sad, and then you're extremely high, extremely happy. Two ends. Okay, so bipolar disorder is different from depression, but bipolar disorder does have depression as part of its range. Okay? So it's not exactly one type of depression. Like the depression is a different story, but bipolar disorder is a different story. But you will have some depression in a bipolar disorder, if that makes sense. Yeah. Borderline personality disorder. Yeah, borderline personality disorder is another group of disorders which I didn't cover because it's like it's a lot for the scope of today. Okay, personality disorder basically means it's almost like it's something that it's a disturbance in somebody's personality that occurs since they're young. Okay, so somebody with borderline personality has mood that goes up and down, but not like bipolar disorder. It's like in a split second, anything can make me super, super sad. Anything can make me super, super happy. It's just up and down all the time. All right. The other thing is there's a lot of self-harming. And there's a lot of fear that people will leave them, to the extent that if you have heard, and we see that more and more now, the threat of being left by the boyfriend, for example, and then somebody just straight away goes into the bathroom, takes the knife and cuts the wrist, or jumps from the building, right? It's a very sudden, very quick decision, straight away. The emotion goes up, they immediately act, and then the emotion takes a long time to calm down and go down and calm down again. That one is a different group altogether. We see this a lot in young people now, especially the girls, although guys do have it as well. We see this a lot. And a lot of the young people who come to us do have depression, but they do also have borderline personality disorder. So it's not one type of depression, but somebody with borderline personality disorder can have depression as well. Borderline personality disorder, it's not exactly something that you treat with medication like depression. It's something that needs psychological treatment as well. So a lot of meeting up with the clinical psychologists and the therapists. Okay, so personality disorders is another group of disorders, and depression is another group. Yeah, they can occur together, but borderline personality is a bit more complex, and you do need to see a proper therapist for it. Of course, in all these things that I'm saying, there's definitely the role of scripture, definitely the role of prayer, coming together as a church and supporting each other, yes. Yeah, although I would advise us to just be careful about how we support, to not be so quick to give spiritual advice too quickly, but to actually consider that sometimes there's a role for medication for some people, there's a role for psychological therapy for some people, and that doesn't make them any less Christian than the rest of us. That doesn't make them any weaker Christians than the rest of us. I think in our churches, we do need to think about destigmatizing medication. Taking medication doesn't mean you don't trust Jesus. Going to see a clinical psychologist doesn't mean you don't rely on the Lord. Sometimes the Lord uses these people, just like the Lord uses doctors to cure our physical illnesses as well. Yeah, in the same way. Yeah. So I hope that answers the question. Feel free to just let me know if you need more information. But borderline personality is a different group altogether. They can have depression too, and we do treat the depression, but the personality disorder must be treated by a clinical psychologist. Yeah, because there's other issues there, a bit more complex. All right.
Thank you, Amanda. Yeah.
No worries. Please feel free to follow up if you have any further questions. I'm very happy for questions because I think we do need to, mental health care must be destigmatized in Christianity.
The bipolar thing was first heard from one of my students. Mother has bipolar, and then she mentioned that the trauma, and then she had bipolar, and I didn't know the term at all. So sometimes, yes, intrigued.
Yes, it's challenging, definitely, and the fact that there's so many groups makes it complex. That's why my first slide today I actually wanted to give us an overview of the different types of things. Yeah. Oh, Jason, long time no see. It has been so long. My goodness.
Hi, Mandy.
Hi. Yeah, Jason, I go way back from the days of lepaking at Mama all the time. In church sessions and stuff. So thank you. You asked why am I pursued to do this work? Well, to be honest, when I went to med school, I didn't have mental health in mind. I mean, I didn't really have psychiatry as a specialty in mind. But I did find that when I was in IMU, the mental health lectures or the behavioral science lectures, right? Why people do what they do, were the ones where I never felt sleepy. That's one. And then when I went to clinical school in Sydney, the rotations when we did our psych block, so the psychiatry block, we rotate in different areas of the hospital. So I did the psychiatry block. I found that was the posting where I felt like, oh my goodness, this makes sense. And I was always interested to go. And then I feel like the end of the day just comes so fast. It's like, 5 p.m., time to go home. And I didn't even feel the day passing. So rather than me choosing it kind of chose me in a way. Yeah. So that's how it grew from there. Yeah. Yeah, so okay, and Alice asks, will the drugs prescribed for anxiety cause patients to be dependent on them if it's for long term? Okay, there is only one group of medications where that can cause people to be dependent long term. Only one. And these are the sleeping tablets. Okay. There's a few groups of medications, okay, but one group of medications, what I call it is, I should type here. Let me type it out here. It's called benzodiazepines. Okay, so benzodiazepines is one type of medication that can cause you to be sort of like dependent on them for long term. So examples of them are things like lorazepam, clonazepam, alprazolam, which is Xanax. You know, if you guys have heard of Xanax, diazepam. Yeah, these are the list. So these are medications that in the long term, people can get a bit dependent on it lah. As in, you may need more doses if you take them for a long time, and sometimes more doses don't have the same effect. So typically, these medications are used to help to calm us down, as well as to help us to sleep. But a good mental health care personnel will advise you to take this for as short a time as possible, and for as little as low a dose as possible for as short a time as possible. Now, if there's a period of time where you are feeling really, really terrible and you're just really, really unwell, then maybe for the first week or two, you may need it every day at a high dose, for example. That does happen. But in a lot of cases, you are being given another medication to treat your mental health problem. So that one should start to kick in by the 2-week mark. It should start to have some effect. So your sleeping tablets should be able to be lowered and to be tapered down. So that's the only group. So sometimes these medications are given in anxiety as well, yes, but they should be given short term. The actual long-term medication that should be taken for anxiety is the same as antidepressants. It's the same group. It's the antidepressants. So if you're going to a private doctor or a private GP or whoever, right, who is only giving you benzodiazepines, only giving you this lorazepam, clonazepam for sleep or your depression or your anxiety, they're only giving you this and they're not giving you the antidepressants, that therapist is not doing a good job. That doctor is not doing the right thing by you. Okay, if they give you benzodiazepines, they should be giving you something else to treat the condition. This is like an infection. Say you have a lung infection, and they give you antibiotics, right, to treat the lung infection. The lung infection will take some time to go away, like say a week or at least 3-4 days. Antibiotics, you will take some antibiotics for 1 week, right? So maybe it takes 3 days for you to feel better, but you're still having the fever. The fever is the Panadol. So you still need the Panadol. And the Panadol is meant to be for short term until your fever goes away and the actual treatment kicks in, the antibiotics. So in this case, an antidepressant for depression or the same medication, antidepressant for anxiety, should be the main treatment, and the benzodiazepine should be short-term treatment only. It's like the Panadol that you take as needed only. But the main treatment for your lung infection is not the Panadol, right? The main treatment is actually the the antibiotics. So in this case, the main treatment should be something else. And if the doctor is only giving you benzodiazepines, then that's not right. They should be giving you something else to actually treat your condition. And the benzodiazepine should be short-term because they can cause dependence. Yeah.
Dr. Amanda, when
yes.
what do you mean by long short term? How short should the period be?
Oh, right. Okay. It depends. It depends on what condition we are talking about. It depends on what condition we're talking about. Say if it's your first episode of an anxiety sort of disorder or a depressive disorder, like an episode of depression, there is a possibility that, say, after 6 months to a year, we can start to reduce it again, reduce the medication again, and see how we go without it. So there is a possibility that you will not need the antidepressants for a long term. Okay. Yeah, it's possible that you will not need it. Certain conditions like schizophrenia and bipolar disorder, these do need long-term medication. But certain others, if it's your first episode, it's not a complicated episode, and things improve over time, like say maybe your life condition improves over time, or you see the therapist and improves, like Pastor David said, with encouragement from Pastor and all that, and things start to look up, right, with spiritual help as well, then maybe over time your antidepressant can be reduced, it can be stopped. But if the depression comes back, then some people do require antidepressants lifelong. Okay, if we're talking about the benzodiazepines short term, because they can cause dependence, we wouldn't recommend beyond 4 to 6 weeks. Usually I try to stop. I try not to keep anybody on it beyond 6 weeks if possible. Although in some cases where the mental health issues are really complicated and really difficult, or the life stress, there's a lot of life stress going on, this person is suicidal all the time, right? It's very, very complex. Then in those cases, unfortunately, and the antidepressants are taking a while to take effect, or they haven't found the right one, right? Or the antidepressants have a lot of side effects and they're still trying to find the right one that works and all that. In those cases, then some people may end up on benzodiazepines longer than that. And sometimes in those cases, if somebody has been on benzodiazepines for 10 years, for example, I'm not going to immediately rush to stop it as well. Maybe we need to do some other things to support the person as well before we talk about slowly reducing it, very, very slowly. Yeah. But if somebody is new to it, I try not to keep them on it beyond 4 to 6 weeks. The shorter, the better. If shorter than that, is even better.
Amanda, I have one more question for you. Amanda.
Oh, yeah. Sure.
Sorry,
all right.
Sorry, too many questions. That's a form of kind of mild anxiety. There was a study done in Australia. They said anxiety is very common in the country. Yes. On average, 1 in 4 people suffer this, and 1 in every 3 women, and male is 1 in 5 men. Why is that so? Why women suffer more anxiety than men?
Yeah, very good question. I think if we were to poll all of us here today, that would probably be true. There will be more women suffering anxiety than men. That's true across the board. One possibility is the fact that women seek help sooner. So women recognize that they have anxiety more than men. They take stock of their emotional condition more than men in some cases. So women tend to seek help faster or sooner. So that's how in the record, there are more women with anxiety than men. Another possibility is the fact that that's how women are wired as well. We're wired to worry, take care of the house, take care of ourselves, take care of the family, take care of, so they're wired somehow to care about a lot of things at the same time. And I think to some extent that does contribute to anxiety, to running things well, taking care of a lot of things at the same time. That does predispose women to anxiety. Not that men don't go through it, but men just process things differently. For men, it's like, okay, I solve the problem, right? I list out these other solutions. Let's work at a way to solve this problem. It's a very problem-solving approach for a lot of men. But for a lot of women, it's a worry approach. It's like, I worry about multiple things at the same time. Even though I can't do anything about it, yet I worry also. I find that a lot in my patients. So anxiety is very, very much more common in women.
So if a man assume the role of a housewife,
maybe
going for suffer this mild anxiety.
He could develop anxiety faster, maybe. It's possible. But then again, a lot of it is sometimes is how we are wired as well. Some people are more easily wired be anxious than others.
Amen.
Yeah?
Thanks a lot.
Right. I have one more question here, I think. One last.
Yeah. There's one question on schizo. I think your earlier question on schizo. What's the best treatment for schizo?
Where was it? Did I miss that?
Yeah, you missed that one earlier. Before.
Is it? Okay. What exactly is the question?
What is the best treatment for schizo? Someone with delusions and mood. Would you treat antipsychotics and with mood stabilizers only?
Okay. Usually the treatment is antipsychotics. The issue is
sorry to interrupt, but actually I asked the question. It's schizoaffective, not just schizophrenia. It's schizo.
Okay.
Same with delusions and mood swings as well, ups and downs. So
that's right. That's right.
Yeah, that's a bit more complicated. Yeah,
were you the one who asked?
Yes, I asked that question. That's right. I asked the question.
Right. Okay. So schizophrenia, of course, is treated with antipsychotics. Schizoaffective is a little bit different. It is both. It's a combination of both. We don't diagnose a lot of people with schizoaffective disorder generally because they need to fulfill very specific criteria from both groups of disorders. But the treatment is, you're quite right, antipsychotics and mood stabilizers. That being said, you may find some people on antipsychotics alone because some antipsychotics have mood stabilizing properties. So they can work as a mood stabilizer as well. So some people are on antipsychotics alone, some are on antipsychotics and mood stabilizers. Yes.
Would you introduce an antidepressant? Because I heard that some antipsychotics can actually cause a low mood. So sometimes it looks as if you might need to introduce antidepressant, but then antidepressants could cause a high. So how would you balance it off?
Yeah, that's the thing though. Okay, it depends.
Right?
For schizoaffective disorder, right? Somebody will have the hallucinations and the delusions as the schizo part, and then the affective part, they can have depression only, or they can have the high the mood swings, right? The mania, we say, the high part of the mood. So if somebody has the high part, we generally don't start the antidepressants. If somebody has a bit of only low mood the entire time, right, and all that, then we may consider an antidepressant still. So a antipsychotic together with an antidepressant, it's possible. But that would be, that would be with a lot of care lah. We need to monitor quite closely. Yeah.
If the person is like having thoughts that other people think is delusions, but the person also has mood swings, but it's more like the person's angry a lot. So not quite manic, but don't know. So it's like but with downs as well. So what's the best? Is it okay to take more than one antipsychotic and just introduce a mood stabilizer like
That would depend on the doctor you're seeing. You see, because sometimes if we have hallucinations, right, voices talking in our ears, or delusions, really believing that something is true and others don't believe it, or others say we are crazy, right, that in itself leads to a lot of anger. That in itself can lead to a lot of mood swings. So we kind of have to see whether this mood swing is actually due to another, like the whole mood disorders or component, the affective component, or whether it's due to, what comes with the delusions and hallucinations and nobody believing. So if it's due to nobody believing me and me feeling just very, very terrible from hearing all these voices and believing all these things, right? Then if we find an antipsychotic that treats that well, then it's possible that that part of it will go away. Yeah, the irritability and all that will go away. It's possible. But then if it's due to the mood swings from the affective part of a schizoaffective disorder, then yes, you do need medication for that. So this one is it is very doctor dependent as well. Whether they will start you another antipsychotic, two antipsychotics together, or an antipsychotic and mood stabilizer. That depends on the therapist or the doctor you're seeing lah. Yeah. All right. Okay. Thank you for that. Anna asked as well, side effects for, if there are any side effects for taking bipolar disorder medications. Okay, it depends. As with all medications, our medications do have certain side effects.
Excuse me, Amanda Liu. I got the list now. Something I want to see the YouTube.
Wait. Raymond, wait first. I have.
Wait first.
Wait first. Yeah.
All right. This one I'll finish up this last question. I think. Will there be any side effects? As with all medications, right? There are certain side effects, but your doctor will know what to do about those side effects. Okay, it's not something that is like unseen or unheard of, right? But It depends also on what medication your brother is taking, Anna. Yeah, it depends. I can't say for sure what the side effects are because it differs based on the medication, but we can observe. Your doctor should be able to observe and tell you lah, as you go along, what exactly the side effects are. It depends on the medication. Yeah. Some people have quite a bit of weight gain. Some people have some, the salt in the blood. There's a fluctuation, a bit low, a bit high. The heart should be checked. Some people have a bit of a rhythm abnormality, right? The heart beats irregularly, but that's quite rare. Some people have no side effects at all, right? It's almost like the vaccine. It's hard to say who gets side effects and who doesn't. All right. So it depends on the medication, but talk to your doctor about it, and they should be. I mean, it should not be something foreign to them. If they're prescribing it, they should know what to do about side effects. All right. His mood is calm, but not focusing whenever we talk to him. Yeah. Sometimes the not focusing may be due to tiredness or things like that, especially if the medication has just been changed. But if you find that he has this problem long-term of not being able to focus or feeling so drowsy, then it's worth talking to the doctor who prescribes it to him and to see whether there are any better options as we go along. Sometimes there are new medications as we go along that may be more suitable. So if you find that there are side effects that are long-lasting, right? A lot of side effects go away within the first few months of taking it. But if a lot of side effects are long-lasting, then you do need to talk to your doctor about it. Yeah. Okay. I hope we have not missed out on anybody's questions.
Yeah,
but if not, next week lah. I'll be with you guys again next week.
Raymond, you got a question, Raymond? Just now the Raymond was asking a question. Yeah.
Oh, yeah.
Raymond, can unmute yourself and ask.
Did Raymond say he has to go?
Okay. Yeah, Raymond. Yeah. Oh, is it? You want to ask?
I want to ask how to let me got confidence, more confidence myself. How to go to the always forget this, forget that.
Okay.
So build up my memory so that I can remember all the things what I do.
All right. I mean, are you seeing a clinical psychologist where at the hospital where are you seeing a therapist or a clinical psychologist of some sort?
No, I didn't see any
You're taking medicine, Raymond. You are still on medication, huh?
John Tan.
Psychiatrist, I think it's psychiatrist.
Okay, yes. But that's a private psychiatrist, is it? Or a government hospital one?
Private, is a private psychiatric.
Okay. Now, what you can do is you can actually ask your doctor whether you can tell him about the things about the memory and the confidence and see whether they can get you to get a referral for you to see a clinical psychologist. Because a clinical psychologist can help with that. One of our patients recently who has had this as well, who's actually very well, the medication is working good for him, but he has a lot of issues with confidence and because of a lot of things that happened in his childhood and in his past, he's had issues with confidence. We got him to start seeing a therapist, a clinical psychologist. And with quite a number of sessions, he's been seeing him for some time. The clinical psychologist helps him to work through his confidence issues and the memory issues as well. Yeah. So they can help you. So they can help you. They can help you with that. You see if you can get a doctor to write a letter to a clinical psychologist. See if he can recommend somebody for you. The sessions are paid sessions in private service. I think like 150 to 200 per session. But if you want to get a referral to government service, also can. They can arrange for you to get.
Amen. Very good.
Right.
Sometimes I feel very down, not don't know what to do like this. Not very happy, and then got some pleasure in my life like this.
Yeah. So maybe you can try that out.
Yeah,
maybe
we can arrange.
try that out.
Yeah.
So some things, sometimes medication doesn't solve the whole problem. It helps with a lot, but it may not solve everything. So sometimes we need to have this as well, some talking therapy, spiritual help, right, from our church and stuff like that. These are things we can do.
Amen.
Yeah.
Great.
Yeah.
Thanks, Amanda. Yeah. Amanda, there's one more question. How does the doctor measure the serotonin levels? Because most of the time it causes depression. And in order to prescribe the right medicine, how do they measure actually that the serotonin levels are actually down, or how do they diagnose that? Yeah.
Right. We can't measure it at the moment. Apart from people who do brain studies and things like that, we don't have any way of measuring it in the blood or anything like that at the moment. The only thing we have close enough to that is the measurement of a stress hormone called cortisol. That's the closest thing we have. But even then, for a lot of people, the cortisol goes up and down during the day. So it's very hard to interpret that result, So we don't have that. A lot of the serotonin measurements are done by people who do the brain studies. They have a certain way of measuring as well. So unfortunately we don't. But a lot of the time when we start people on treatment, like antidepressants, which help to increase serotonin levels in the brain, then we see the effects in the patients, in the symptoms they experience. They start to feel a bit happier, they feel a bit more energetic, they can concentrate, things like that.
Yeah. Very good. Okay, great. Unless you have any really, really urgent questions to ask now, we'd like to call it a day and give a big thank to Dr. Amanda for joining us today.
Amanda. Thanks, everyone.
See you next week for another interesting talk.
See you next week.
See you all next week.
See you next week. Okay, bye.
Call about